Welcome to the next episode of Endoscopy Essentials, and welcome back, Jeanin van Hooft. Jeanin, we now go into something a little bit complicated. It's liver transplantation. So if you are an endoscopist at a center, there are some procedures which depend on endoscopy. So if you go into resection, people are sent because you are doing resection. But if you are a good pancreatobiliary endoscopist, you are dependent on the environment where you're working because your cases mostly come from the hospital. So if there is a pancreatic cancer surgery, biliary cancer surgery, you will have a lot to do. And one thing is liver transplantation. So if a center has liver transplantation, maybe you tell us your own experience, how you got into it, and what were the new features, etc., and what a young endoscopist should watch out for.
Okay, thank you. I have to say I have been working at the Amsterdam University Medical Center for several years, and then I embarked on a new challenge. I went to the Leiden Medical Center, and that's a transplant center. And I considered myself quite as an established ERCPist, but then I suddenly had to do this liver transplant patients, and everybody there was talking about CAST and ECBL, and I was really a bit like, okay, what's this all about? So I had to get myself familiar with this kind of systems, and I would actually like to take you along a bit with the basics I had to go back to. I will show you the first slide. It's about what happens after a transplantation. And if you do a transplantation, the biliary tract is damaged. That means there's ischemia time, there might be leakage, there might be an abscess after the transplantation.
So you mean there's always some kind of damage, most often very minor, but ischemia is part of it, right?
Yeah, ischemia is part of it. Most of the patients will, it won't be really a problem. But in about 30% of the patients, they will develop strictures, and there can be sooner or later. What we actually see in the first phase is that they might develop a cholangitis. And the cholangitis is then often based on this kind of casts. So after this ischemic period, the biliary tract is going to be renewed. And then you get, it's not really stones. It looks like stones, but it's really the whole biliary tract can be filled with this kind of casts. And thereafter, only in a later phase, you might get strictures.
So casts, does it feel like a little bit of pancreatic necrosis? Is sticky stuff, brownish stuff? Is it hard?
No, it's soft. I can actually show you some pictures of that. I take you down in just a sec. So if you can appreciate here, this is a picture of a cast. So you can actually see that what happens is you get really this whole kind of biliary tract you can take out. It's relatively soft. And you can have really a kind of copy of the whole biliary tract. And especially after this phase, many patients will develop strictures.
So the earlier phase is casts,
yeah,
and then the strictures follow.
Yeah.
But the underlying principle is the same, ischemia.
Yeah.
Okay. So of course the hepatologists decide when the endoscopist is coming in, and that's usually, as you said, cholangitis or elevated liver enzymes. Does imaging help? So do you need to do whatever, maybe ultrasound, that's simple, but MRCP, is it mandatory?
Yeah, so especially in the early phase, this cast you won't see on an MRI. What you see after the transplantation is that the liver enzymes are raising and that they might get this kind of, 38 degrees, a bit febrile. And then most of the times the hepatologist will say, okay, Jeanin, can you look if there's cast? So that means that the patients are scheduled for an ERCP. And also there I learned quite a bit because this biliary tract is different from what you're used to. Often this own part of the CBD is really dilated, and then it can be really tiny. And you really have to look close for cast because it's not like stones, it's not that visible. It's a kind of, blurry image you get. You think, is this really all complete? and you will need a relatively large balloon to really get it out. But otherwise, if you take a too small balloon, you just squeeze it into the walls and you think, oh, there's nothing here. But then the patient will come back with a fever.
Are these difficult patients, difficult papillas? I mean, some of the patients may, like the PSC patients, may have had ERCP before, but otherwise, high pancreatitis risk? In addition, on top?
I think that's a very intriguing question, because we are right at the moment looking into the data, because I had the feeling that those patients are more susceptible for a post-ERCP pancreatitis. Next to that, it's our frail patients. They just have gotten their transplantation. They are just a month after the transplantation or a bit more. They're on high immune suppression. They're still recovering. So if you do harm, you really do harm. So I think you really have to realize, and also on beforehand, before you do this procedure, really talk extensively with the patient and the family.
So all what you have for post-ERCP pancreatitis prevention you will use?
Yeah, and I'm anyhow really a believer of the NSAID, so I will easily give it to the patient. Sometimes, especially those liver transplant patients, do also have kidney problems. But I would, kind of easily overrule that and say, okay, if this patient in addition get a pancreatitis, it's really, really very cumbersome.
Yeah. Fluid?
Not in particular, but antibiotics, yes. I'm very keen on that. Often they have already antibiotics because they do have a cholangitis. Sometimes not, because they have just a 38 degrees. Nobody really wants to put them on antibiotics, but as soon as you do an ERCP, you really have to give them antibiotics.
Okay, so cannulation is successful. Sphincterotomy? Some people say as small as possible because of the risk of ascending cholangitis. Is that rubbish or?
Yeah, I think the data are very frail. What I normally do as soon as I get in is I try to make a good cholangiogram. Because if I have done the sphincterotomy, then the contrast runs off quite easily. And I think the really essential is that you get a good overview of the biliary tract. So that's the first thing I do.
And before that, you take bile for microbiologic analysis?
We don't do it. I do know that there are centers that take it. So I think that differs per center.
We are doing it, but yes.
Yeah, so I make a cholangiogram, see what's around, and then yes, I do a sphincterotomy. Also to facilitate most of the time those patients do need more procedures. So it's not only the one you do today, but you will see them back several times. I do a relatively small sphincterotomy because in principle I don't have to remove large stones. So why should I do a very large sphincterotomy? Those patients are also often on anticoagulation therapy, so I only think, okay, I might have to put in 1 or 2 stents, so that would do this. So yes, I do a sphincterotomy, but not a really large one.
Ballooning instead? Or?
Ballooning is definitely an option. So I also sometimes, depending on what kind of cast I'm going to take out, I do ballooning. Depending also on the remnant CVD, because that's sometimes very dilated already in that phase. But in principle, I would do a dilation of 10 to 12 millimeters at most.
Okay, so do you have some pictures for us?
So you have different kind of strictures you can encounter with patients after liver transplant. You have the one at the anastomosis. You can have a larger one actually of the whole CVD, but you can also have it intrahepatically and also really have it in the small branches. And if you have it in the small branches, you will see that there are just no small branches.
If I look at that, the question is always, if you want to have a perfect ERCP, you have to inject a lot of contrast. So what's the cutoff here? How much to inject?
Yeah, I think that's intriguing, because if you put in lots of contrast, you also definitely assure that your patient later in the evening will have spiking fever. So that's indeed the trade-off. What I normally do is that I start with a bit of contrast. I mean, if you immediately see a very tight stricture at the anastomosis, it doesn't make sense to at the same moment also try to visualize the whole biliary tract.
So fix this first and then see.
Exactly. And sometimes if you do not see another stricture elsewhere, you thought, okay, maybe it's really into the small branches. So only then I would put in a more contrast.
More contrast, okay.
So actually I'd like to show you a video which has been made by one of my colleagues. And this is actually what I just said. You go in with a balloon, you give your contrast, you really have a keen eye on what's missing. And if you sweep down with a balloon to see what you extract. And actually interesting to me, you also always see the clips. So you know that there is definitely damage to the biliary tract. What we do here is that we went in with a cholangioscope, and here you can see the image where we're heading with the cholangioscope down and trying to get into the biliary tract. To also see, I mean, at a certain moment you think you have removed all the casts, but it will be quite remarkable to see what's still left. And also to be sure that there's no other damage than just the cast and eventual strictures. So here we're going in. You nicely adjacently see the image under fluoro.
It's a direct cholangioscopy.
It's a direct cholangioscopy. We do that more often. It has a good image quality, and the only thing is you're depending if the biliary tract is large enough. But here you can see the casts. So this is what we're talking about. So you then can also see it's a kind of soft. It's not like stones. And here we're going to try to take it out. You see also that the other biliary tract looks really quite okay, a bit of scarring, but otherwise no really abnormalities. And then we just remove it. Here you see coming it out, and I think this is a typical cast. So I hope I could demonstrate a bit how that looks like, and you can actually also see a bit the feeling.
But it's really similar to pancreatic necrosis.
It doesn't smell.
It doesn't smell, okay, because it's too small.
Yeah. So here you can appreciate actually an overview. If all the cast is out, it looks normal again. Unfortunately, we also injected the pancreatic duct quite a bit, but I can tell you that there was no problem with this patient.
That's normal now.
Yeah, it looks really normal now. So I think really if you have the cast out, it looks normal. But then they come back in 3 months' time.
Can you predict anything? So is a cast always a significant amount of cast always followed by strictures, or vast majority? Or
No, but if my patient has had cast, I have really a keen eye on this patient, because it is affected. The chance that this patient gets a stricture is higher.
So you bring him or her back routinely?
No, they are followed really closely by the hepatologist, and if then the liver enzymes are raising again, then I definitely would schedule them again. And there sometimes the hepatologists make first an MRI, because they then don't believe it and they really want to be sure that there's a stricture, but I can tell you there will be a stricture.
Finally end up at the ERCP at some stage.
In the end, they end up at the ERCP.
So that's the early phase. It's ischemia, that cast, and the main challenge is, A, you don't see the cast so well. I think that was nicely shown in that video. And B, the aim would be total clearance, if possible.
Yeah.
So then, second period, stricturing.
So then you get the stricturing, and then you have all kind of different kind of strictures, actually, as we just briefly highlighted before. I think the most common stricture you see is at the anastomosis. So that's where I would first have the close look. I think you can see it here on this image. So you go back, you reschedule. I tend to go in, if I have done a sphincterotomy before, I directly cannulate with an extraction balloon. I make again a cholangiogram, and I think what I like with the extraction balloon is that I can feel the stricture. So if you go down, you really feel the stricture, and in first instance I would dilate. So also for that, we do not have anesthesia sedation, but we work with propofol. But if I do this on the propofol before dilating, I tell my sedation specialist, okay, this is really going to hurt the patient. So they are prepared, and it's not only at the moment it might hurt the patient, but also afterwards if they wake up. So you do dilate, and then is of course the question, what are we going to do? In this patient, as I show here, we started with plastic stents, as you can see over here. There's of course always the question, plastic or metal. And there I have also really a close look between where is the stricture and where is the hilum.
And how big is the bile duct?
Absolutely. And especially if the bile duct is very, very tiny and you put in a metal, the patient is really going to dislike you because of the pain. It's really cumbersome.
But is there a question just to balloon the patients, balloon dilatation versus stenting? That's what our hepatologists tell us. We should rather do a balloon dilatation and place only a stent if it was a very difficult procedure or something special.
Yeah, I think that comes especially from the PSC. And I think in the PSC we also really, the first treatment would just be only dilation. But here it's about remodeling. There's something, there's ischemic damage. And most of the patients cannot just be managed with dilation. So we really tend to put in plastic endoprothesis. And sometimes that's already cumbersome. You end up with this, 7 French endoprotheses to put in. And then we schedule them on a regular basis to see if we can upgrade.
Because the argument is, or we hear, is that stent is a source of infection.
That's true.
But with any ERCP, and maybe even before, there's infection anyway. So it's difficult.
Yeah, I think as soon as we go in with the ERCP, we do infect this biliary tract. So, and then we see if we can settle it with plastic endoprothesis.
So do you then have maybe a short stent exchange interval?
Yeah, most of the time shorter than with ordinary treatments. So most of the time we reschedule them within 6 to 8 weeks. To see if we can upgrade. I have to say, honest, some patients even don't make the 6 to 8 weeks. I think there is still also that they have this kind of cast development with blockstone stents earlier. And I think also there you really have to prepare the patients, that you say, okay, you now have a kind of business card to come to our unit, and we're going to see you quite frequently.
Okay, so maybe in the future the intervals will even become shorter.
Yeah, unless you could manage it with a metal stent. I think also that's what we did. That's what you can appreciate in this patient. You see really a tight stricture with also the clips there, so that's ischemia. We balloon dilated it, and then we work with this coffer stent. So that's a stent that's just and only placed within the biliary tract and has the strings going out into to the duodenum. We also actually did a trial with that, comparing it with the plastic endoprothesis. Has been published in GIE last year to see what's actually better, plastic endoprothesis or the metal ones. The advantage of the metal ones is that you can send the patient away for half a year. Okay.
But that's the classic for that is an anastomotic stricture, and the more complex and proximal it gets, the less you would place metal stents.
Yeah, so if it's, I think the metal are, in my opinion, only for the anastomotic strictures. And I have to say that most of the time, these anastomotic strictures you can manage. Within a year, you have them under control. The more cumbersome strictures are the strictures either at the hilum or even intrahepatic.
And diffuse ones.
Yeah, and the diffuse ones, and actually even for the diffuse ones, we sometimes have to go for retransplant.
Okay, I think what my experience is that you can do a lot of good initially, but when ischemia goes on, then the benefits of ERCP become less.
Yeah. The trade-off is reoperation, and most of the surgeons are not, really eager to reoperate on this kind of vulnerable patients. Sometimes we end up with retransplantation, which is also tough for the patients. But I have to say, we have some patients who have had 3 liver transplants, and finally it's going to be okay. And also, quite surprisingly, some patients come back, you have settled it, they go out, and then 1 or 1.5 years later, they're back and they have again a stricture. And those are even more difficult to treat.
Oh, absolutely. That brings me to the question, how long is the routine stenting period? For plastic stents, more complex strictures, let's say hilum, What's your end point? Or do you go on forever? Is it morphologically, or if the patient is clinically fine, you make an attempt to leave the stent out?
Yeah, I think that's really an intriguing question. I think the problem there is that the patient is often treated by another endoscopist. So I do the first procedure, then somebody else does the second, and then nobody dares to take the stents out. I try to do so. So what I often do, if I've seen that a patient is in this kind of trajectory for nearly a year, before I do the procedure, I tell the patient, okay, I'm going to look if I can leave them out. Are you going on holiday? So I want to be sure that, if what I do is not okay, that they're not somewhere, outside traveling, but that they can come back to the hospital quickly. Because I think you at a certain moment have to take the, in between brackets, risk to dare to leave the stents out. And I think that's a difficult decision.
Well, it is. By your experience and gut feeling, how often do you think patients can live without stents for a longer time? Is it 30% or more?
Yeah, I think it's about 40 to 50%. But I'm also happy already if they are without stents for 1.5 or 2 years, because I think then I saved them quite some procedures already. And yes, sometimes they do come back in the long run.
Good. So it all depends on the clinical situation, follow-up. So these are patients who often come to the hospital outpatient departments, hepatology, etc. Okay, Jeanin, that was a brilliant introduction into this difficult field. It also shows that, as you mentioned, interdisciplinary work is decisive starting with making the indication and then, making a long-term concept. And there's a lot of talking to the patients as well.
Yeah. Absolutely. And you hope that in the future we could prevent this.
Tell us how. Us or the surgeons or the people taking care of the liver? Or?
Yeah, I think especially it's about the liver. Of course, the body has a natural reaction to kick this new liver out. And there are bacteria in this liver, so should we flush the liver before we retransplant? Should we put this liver on an oxygenative machine before? I think that's really research to be done and actually also going on. And I think it has also to do with the shortage of livers we have to be transplanted. So what we can transplant, we should do on the best way and try to avoid this kind of complications.
So that's a mixture of how you treat the liver and how you treat the immune reaction of the patient. And we are there to help the patient, but we are palliating.
Yeah, and I think we are only, as you said, one of the players in the team, because I think also the immunosuppressives are very important. So they should be on the really exact right level, which is not so easy.
Okay, good. So thank you very much. And I'm very much looking forward to have you back for another pancreatitis biliary topic, maybe EOS. Thank you.
Thanks.